Bismillahirrahmanirrahim and Assalamu alaikum. Today I am giving the presentation on the case study of hyperthyroidism. Raila, a 36 years old school teacher, visits a general physician with complaints of swelling in neck, diarrhea, feeling of warmth and excessive sweating for 5 weeks. She also complains of nervousness and irritability. She has noticed a 6-pound weight loss over the past 2 months despite an increase in her appetite. Discussion questions would be: find out the meaning of difficult words, list the key information Rahila, identify Rahila's presenting problems and generate hypotheses. What further information would you like to ask in history to help you differentiate between your hypotheses? 36-year-old female school teacher. Now, the presenting problems: swelling in neck, diarrhea, feeling of warmth and sweating, nervousness and irritability, loss of weight. Hypothesis: there are the depending on the symptoms. Swelling, neck swelling. She is complaining of neck swelling. What would be the causes? It might be skin abscess, swollen lymph node due to bacterial or viral infection, swollen salivary glands, lump in muscles of neck, enlarged thyroid gland, brachial cleft cyst or thyroglossal cyst. Diarrhea. The causes may be bacterial, viral or parasitic infection, food allergy, inflammatory bowel disease, reaction to medicine or hyperthyroidism. The causes of feeling warmth and excessive sweating might be anxiety, hyperthyroidism, if use of caffeine, amphetamines and menopause. Nervousness, depression, bipolar disorder, dementia, premenstrual syndrome, low blood glucose, sleep problems, stress, hyperthyroidism, drugs and medication. Weight loss may be due to type 2 diabetes, overactive thyroid, celiac disease, irritable bowel syndrome and heart failure. Rahila is also experiencing some sandy sensations in eye and feeling of eye pressure. Moreover, she is unable to concentrate on teaching and pay attention to her students because she feels anxiety and restlessness all the time. She also feels uncomfortable in a warm room. Replying to a question, Rahila informs that she is a resident of Karachi and never lived in any hilly region. She has no history of any major medical illness in the past. Her father has type 1 diabetes and her mother has rheumatoid arthritis. Her 2 brothers and a sister are healthy. Socioeconomic history is satisfactory. Her personal history reveals she is married 9 years back and her daughters are 7 and 5 years old. Discussion question: list the different words and list the difficult words and find out their meaning. Summarize the key information in this progress. What is the importance of family history? What clinical examination and investigation would you like to do for the diagnosis of this patient? Family history importance. Difficult word: sandy sensation in eye, dirty, filthy, unpleasant or tiredness. Family history importance: parents have autoimmune disorder, father has type 1 diabetes and mother has rheumatoid arthritis. A cousin also has hyperthyroidism. Clinical examination reveals that Raila is a middle-aged woman, well-oriented with time, place and person. She has an obvious swelling in front of the neck, fine tremors of both hands, palms are sweaty and warm, exophthalmos is evident by her protruding eyes. Blood pressure reveals 149 by 90 mm of mercury. Pulse is 130 times per minute, irregular. Respiratory rate is 18 times per minute. Temperature is 38 degrees centigrade. BMI is 26. Thyroid gland is enlarged symmetrically, non-tender, moving on swallowing. Skin over the gland is warm and moist to touch. Systemic examination reveals CVS system will be showing S1, S2 audible, tachycardia, no murmurs. Respiratory system normal, vesicular breathing, no added sound. Abdomen is normal on examination. Sensory and motor system intact. Hyperreflexia and fine tremors in outstretched hands. Lab investigation. Rahila is advised certain blood tests including complete blood count, fasting blood glucose level and thyroid panel, and you may coordinate the Rahila's blood investigation results with with that of the normal value and you can make your definite diagnosis. Questions: what is the commonest structural enlarged in front of the neck in hilly mountain areas of Pakistan? Which endocrine gland is involved in this case? What are the normal functions of thyroid hormone in the body? Discuss the underlying mechanism of these symptoms, how iodine is incorporated in thyroid hormone, and what other macromolecules are involved in this synthesis, how thyroid hormone secretion is regulated, how thyroid gland abnormalities are investigated on biochemical ground. How would you address patients' concerns regarding swelling in front of the neck? Anatomy and histology. Thyroid is the largest endocrine gland, weighing 15 to 25 grams in adults, consists of two lobes joined by an isthmus, located on either side of the trachea just below the larynx, receives high blood supply 400 to 600 milliliter per 100 gram per minute, greater than heart and kidney. Histology. Each lobe of the thyroid is divided into many lobules by fibrous septa, and each lobule is made up of several follicles, which is a functional unit of thyroid. Each follicle is lined by cuboidal follicular cells that rest on a basement membrane filled with colloid. Scattered between follicular cells are the parafollicular cells, which secrete calcitonin. Synthesis and secretion of thyroid hormones. Iodide is actively transported from the blood plasma into the thyroid follicle cells by sodium iodide symporter. Iodide and thyroglobulin are secreted in the lumen. Iodide is oxidized to iodine and attached to tyrosine in thyroglobulin, forming mono and diiodotyrosine. Coupling of monoiodo and diiodotyrosine forms triiodothyronine and thyroxine T4. Under the influence of thyroid stimulating hormone, the colloid is taken up by endocytosis into thyroid follicle cells and stored. T3 and T4 are removed from thyroglobulin and secreted. T3 and T4 secreted in blood in association with plasma protein, 75% with thyroid binding globulin, 20% thyroxine binding prealbumin, and 5% with albumin. Functions of thyroid gland: accelerate the metabolic rate and oxygen consumption in all body tissue, increase the body temperature, that is thermogenesis, affect the growth and development in early life, accelerate the glucose absorption, carbohydrate metabolism required for normal protein synthesis, and is an anabolic hormone required for hepatic synthesis of vitamin A from carotene and conversion of vitamin A into retin. In hypothyroid state, serum carotene is elevated and skin looks pale. Enhance the effect of sympathetic division of autonomic nervous system. Critical role of iodine in thyroid gland and how its transport is controlled. Iodine deficiency reduces thyroid hormone synthesis. Recommended iodine intake is 550 micrograms. The recommended minimum intake per day is 150 microgram and about 1 milligram per week to maintain euthyroid state. Iodide is added to salts and iodate is added to bread. During pregnancy, requirement is 200 micrograms per day and neonatal iodide requirement is 40 micrograms per day. Iodide is transported to thyroid follicles by sodium iodide symporter. An enlargement of thyroid gland is called a goiter. It does not specify the functional state of thyroid gland. Hence, a goiter may be associated with a hypo or hyperthyroidism. Background: thyrotoxicosis is the hypermetabolic condition associated with elevated levels of 3-thyroxine, free triiodothyronine. Hyperthyroidism includes diseases that is a subset of thyrotoxicosis that are used by the excess synthesis and secretion of thyroid hormone by the thyroid gland. They are not associated with exogenous thyroid hormone intake and subacute thyroiditis. Most clinicians, exclusive of endocrinologists, use the terms hyperthyroidism and thyrotoxicosis interchangeably. Most common forms of hyperthyroidism include diffuse toxic goiter Graves' disease, toxic multinodular glotopalmar disease, and toxic adenoma together with subacute thyroiditis, and these condition constitutes 85 to 90% of all causes of thyrotoxicosis. Table 1 contains a list of hyperthyroid conditions associated with thyrotoxicosis. Now, this is the common forms of thyrotoxicosis and hyperthyroidism. and I have given the level whether the radioactive uptake over the neck is increased or decreased, and this comparison will help us to make the definite diagnosis of hyperthyroidism. Now, less common forms of thyrotoxicosis and hyperthyroidism. This is the iodide induced thyrotoxicosis. The radioactive iodine uptake over neck is variable, or thyrotoxicosis facicia, that is decreased level. There is the radioactive iodine uptake level is being seen decreased. Now, uncommon forms of thyrotoxicosis and hyperthyroidism. Pituitary tumors producing thyroid stimulating hormone, the radioactive iodine uptake over neck is increased. Excess human chorionic gonadotropin, molar pregnancy, or choriocarcinoma is increased. Pituitary resistance to thyroid hormone is increased. Metastatic thyroid carcinoma is decreased. Pathophysiology. The hypermetabolic effect of thyrotoxicosis affects every organ system. The pituitary gland stimulates the thyroid and make the thyroid hormone, which is released into circulation, reach each and every cell in the body. Thyroid hormone is necessary for all normal growth and development. It regulates cellular metabolism. Excess thyroid hormone causes an increase in the metabolic rate that is associated with increased total body heat production and cardiovascular activity, increased heart contractility, heart rate, and vasodilation. Graves' disease. The most common cause of thyrotoxicosis is Graves' disease. 50 to 60%. Graves' disease is an organ-specific autoimmune disorder characterized by a variety of circulating antibodies, including common autoimmune antibody as well as anti-thyroid peroxidase and anti-thyroglobulin antibodies. The most common antibody there is thyroid-stimulating immunoglobulin, and thyroid-stimulating immunoglobulin is directed towards the epitopes of thyroid-stimulating hormone receptor and acts as a thyroid-stimulating hormone receptor agonist. Similar to the thyroid-stimulating hormone, thyroid-stimulating immunoglobulin bind to the thyroid-stimulating hormone receptor on the thyroid follicular cells to activate the thyroid hormone synthesis and release and thyroid growth, that is the hypertrophy. This results in the characteristic picture of Graves' thyrotoxicosis, which are diffusely enlarged thyroid, very high radioactive iodine uptake, and excessive thyroid hormone level compared with a healthy thyroid gland. The thyroid hormone level can be extremely elevated in this condition. Clinical findings specific to Graves' disease include thyroid ophthalmopathy, periorbital edema, chemosis, conjunctival edema, injection, proptosis, and rarely dermopathy over the lower extremities. This autoimmune condition may be associated with other autoimmune diseases such as pernicious anemia, myasthenia gravis, vitiligo, adrenal insufficiency, and type 1 diabetes mellitus. Graves' disease symptoms: exophthalmos, goiter, arrhythmia, tachycardia, nausea, diarrhea, oligomenorrhea in female, that is the decreased menstrual cycle, muscle weakness, tremors, sweating, headache, weight loss, nervousness, and emotional instability. Iodine 123 nuclear scintigraphy. The iodine 123 nuclear scintigraphy, iodine scans of a normal thyroid gland. Common hyperthyroid condition with elevated radioactive iodine uptake, including Graves' disease, is shown in B section of the picture. Toxic multinodular goiter is seen in C portion of the picture, and toxic multinodular adenoma is seen in D portion of the picture. Color flow ultrasonogram. Color flow ultrasonogram is in a patient with Graves' disease. Generalized hypervascularity is visible throughout the gland, which often can be heard as a hum or bruit sound with a stethoscope. Subacute thyroiditis. The next most common cause of thyrotoxicosis is subacute thyroiditis, approximately 15 to 20%. A destructive release of preformed thyroid hormone. A typical nuclear scintigraphy scan shows no radioactive iodine uptake in the thyrotoxic phase of the disease. The thyroid hormone level can be extremely elevated in this condition. Multinuclear giant cell granuloma. These three multinuclear giant cell granuloma observed is a fine needle aspiration biopsy of the thyroid from a patient with thyrotoxicosis from some acute painful or granulomatous thyroiditis. Toxic multinodular goiter plumber disease occurs 15 to 20% of patients with thyrotoxicosis. It occurs more commonly in elderly individuals, especially in patients with a long-standing goiter. Thyroid hormone excess develops very slowly over time and often is only mildly elevated at the time of diagnosis. Very high thyroid hormone levels may occur in this condition after high iodine intake with contrast or amiodarone exposure. Symptoms of thyrotoxicosis are mild, often because only a slight elevation of thyroid hormone level is present, and the signs and symptoms of thyrotoxicosis often are blunted, apathetic hyperthyroidism in older patients. Scan in patient with a toxic multinodular goiter. Scan in a patient with a toxic multinodular goiter. The 5-hour iodine uptake was elevated at 28%. Note the multiple foci of variable increased tracer uptake. Toxic adenoma is caused by a single hyperfunctioning follicular thyroid adenoma. Patients with a toxic thyroid adenoma comprise approximately 3 to 5% of patients who are thyrotoxic. Excess secretion of thyroid hormone occurs from a benign monoclonal tumor that usually is larger than 2.5 centimeter in diameter. The excess thyroid hormone suppresses thyroid stimulating hormone levels. Radioactive iodine uptake usually is normal, and radioactive iodine scan shows only the hot nodule with the remainder of the normal thyroid gland suppressed because the thyroid stimulating hormone is low. Other causes of thyrotoxicosis. Several rare causes of thyrotoxicosis exist that deserve to be mentioned. Iodide-induced thyrotoxicosis, George-Basdeo syndrome, occurs in patients with excessive iodine uptake, such as after an iodinated radiocontrast study. It occurs in patients with areas of thyroid autonomy, such as a multinodular goiter or autonomous nodule. The thyrotoxicosis appears to be a result of loss of normal adaptation of the thyroid to iodide excess. It is treated by cessation of the excess iodine intake and administration of anti-thyroid medication. Usually after depletion of the excess iodine, thyroid functions returns to the pre-exposure level. Struma ovariae is ectopic thyroid tissue associated with dermoid tumors or ovarian teratoma that can secrete excessive amounts of thyroid hormone and produce thyrotoxicosis. Metastatic follicular thyroid carcinoma maintains the ability to make thyroid hormone and can cause thyrotoxicosis in patients with bulky tumors. Molar hydatidform pregnancy. Patients with a molar hydatidform pregnancy or choriocarcinoma have extremely high levels of beta-human chorionic gonadotropin that can weakly activate the thyroid stimulating hormone receptor. At very high level of beta-human chorionic gonadotropin, activation of thyroid stimulating hormone receptor occurs that is sufficient to cause thyrotoxicosis. Physiological maximum elevation of beta-human chorionic gonadotropin at the end of the first trimester of pregnancy is associated with a mirror image temporary reduction in thyroid stimulating hormone. Despite the reduction in thyroid stimulating hormone, the follicular T4 cell level usually remains normal and only slightly above the reference range. As the pregnancy progresses, the beta-human chorionic gonadotropic plateaus at a lower level. The thyroid stimulating hormone level decreases back to the normal levels. Clinical feature. The presumption of thyrotoxicosis is variable among patients. Thyrotoxicosis leads to an apparent increase in sympathetic nervous system symptoms. Younger patients tend to exhibit symptoms of more sympathetic activation such as anxiety, hyperactivity, tremors, while older patients have more cardiovascular symptoms including dyspnea and atrial fibrillation with unexplained weight loss. The clinical manifestation of thyrotoxicosis do not always correlate with the extent of biochemical abnormality. Common symptoms of thyrotoxicosis: nervousness, anxiety, increased perspiration, heat intolerance, tremor, hyperactivity, palpitations, weight loss despite increased appetite, reduction in menstrual flow, or oligomenorrhea. Common signs of thyrotoxicosis: hyperactivity, tachycardia, atrial arrhythmia, systolic hypertension, warm voiced, smooth skin, lid lagged, stare, tremors, muscle weakness, and neck swelling, that is the goiter. Symptoms of thyrotoxicosis: generally a constellation of information including extent and duration of symptoms, past medical history, social and family history, physical examination help to guide the clinician to the appropriate diagnosis. Subclinical hyperthyroidism is associated with no clinical symptoms of thyrotoxicosis. However, certain conditions such as atrial fibrillation, osteoporosis, or hypercalcemia may suggest the possibility of thyrotoxicosis. In fact, subclinical hyperthyroidism may be associated with a threefold increase in the risk of atrial fibrillation, and the prevalence of subclinical hyperthyroidism may be as high as 12% in general population. Graves' disease. The frequency and severity of symptoms of thyrotoxicosis vary from person to person. Graves' disease is an autoimmune disease, and often a strong family history or past medical history exists with autoimmune disease such as with rheumatoid arthritis, vitiligo, or pernicious anemia. Investigation for Graves' disease. Blood test can help your doctor to determine your level of thyroid stimulating hormone, the pituitary hormone that normally stimulates the thyroid gland, and your level of thyroid hormones. Radioactive iodine uptake, ultrasound, and the imaging test. Now, the treatment for the Graves' hyperthyroidism is conservative and ablative. Conservative antithyroid drugs, high relapse rate. Ablative is radioiodine and thyroidectomy and lifelong hypothyroidism. Thank you. That was all about the case study of hyperthyroidism.